The title of this talk is Anatomy of the Eye and Common Eye Pathology. These are the class objectives. You do not need to read them. We will use them to chart. This talk will be conducted using a question and answer format. The first question is, which of the following structures is only present in the upper eyelid? A. Tarsal plate. B. Muscle of Mueller. C. Levator palpebrae. D. Palpebral conjunctiva. I will use this cartoon to indicate some important ocular landmarks. Eyelids, tarsal plate, cornea, levator palpebrae, which is innervated by the third cranial nerve, the muscle of Mueller, a sympathetic innervated muscle that attaches to the tarsal plates, the insertion of the recti, superior, lateral, inferior, the palpebral conjunctiva, the bulbar conjunctiva, which you can see here delineated by the brackets. So the answer to this question is C. Next question. Which of the following structures is primarily responsible for the production of the substance that prevents the eyelids from sticking together when closed? A. Ciliary gland of moles. B. Meibomian glands. C. Glands of Say's. D. Sweat glands. I will now remove from this cartoon the eyeball and other structures to emphasize the structures in the enclosed area. In this new cartoon, you can see eyelid structures in more details. I will use this cartoon by highlighting the eyelid muscles, orbicularis oculi, to which I am indicating in this frame, the levator palpebrae, here indicated, the muscle of Mueller, which are present in the upper and lower eyelids attached to the tarsal plates. I will also use this cartoon to highlight some glands. The ciliary gland of mole, which are modified sweat glands, here indicated. The glands of Say's, which are modified sebaceous glands, here indicated at the root of the eyelashes, and the Meibomian glands, also known as tarsal glands because of their location in the tarsal plates. They are modified sebaceous glands. The function of these glands is to secrete a substance that slows evaporation of tears and prevents the eyelids from sticking together when closed. So the answer to this question is B. Next question. The limbus forms the border between the transparent cornea and the opaque sclera. A. True. B. False. The limbus form the border between the transparent cornea and the opaque sclera as indicated in this frame. So the answer to this question is A. Next question. Which of the following entities is not considered an infectious process? A. Chalazion. B. Hordeola externum. C. Hordeola internum. D. Blepharitis. Now we are going to mention few conditions that affect the eyelids. The first of these conditions I want to mention to you is chalazion. A chalazion is characterized by a relatively confined swelling of the eyelid. This chalazion is in the lower eyelid, but they can also occur in the upper eyelid. Chalazion is a non-infectious obstruction of the Meibomian glands, as represented in this diagram and indicated by the arrow. Chalazion are due to obstruction of the Moebian gland and accumulation of Moebian gland secretion. The accumulated material often leaks outside the gland. Extravasation of the irritating lipid material produces focal secondary granulomatous inflammation of the eyelid. Risk factors for chalazion are Moebian gland dysfunction and acne rosacea. The treatment of chalazion consists of applying warm compresses to the eyelid for 10 to 15 minutes, 4 to 6 times a day for several days. Gently massaging the external eyelid for several minutes each day to help promote drainage. Keeping the area clean, especially when the chalazion drains on its own. If the chalazion persists for several weeks, ophthalmology consult for incision and steroid injection may be needed. Another common condition affecting the eyelid is hordeolum externum. Hordeolum externum, better known as style, is an acute localized swelling of the eyelid, usually due to pyogenic, typically staphylococcal infection. Hordeola externum results from obstruction and infection of eyelashes, follicles, and adjacent Say's glands or mole glands. Follicle obstruction may be associated with blepharitis. Another condition you need to know about is hordeolum internum. This condition, as hordeolum externum, is an acute localized swelling of the eyelid, usually due to pyogenic infection. The difference is that in hordeolum internum, the site of affection is the meibomian glands. Cellulitis may be accompanied by hordeola internum. Treatment of hordeola consists of warm compresses, gentle massage, keeping the area clean, topical ophthalmic antibiotics, and systemic antibiotics if cellulitis is present. If worsening after initiating treatment, absence of improvement in a week, or if not completely resolved in several weeks, an eye doctor consultation is warranted. The next condition we are going to talk about is blepharitis, also known as lid margin disease. Blepharitis is a skin condition, often produced by bacterial infection, Staphylococcus aureus being the most common. But at times the irritation can be caused by lice or mites. As you can see in this photograph of lice blepharitis and mites blepharitis. The treatment of blepharitis includes treatment of the primary skin condition or infestation, warm compresses, gentle massage, keeping the area clean, topical antibiotics. If the condition persists, the patient should be referred to an eye consult. The condition shown in this picture is molluscum contagiosum. The lesion consists of enlargement and distension of epidermal cells with pox virus inclusion. Patients with this condition should be referred to ophthalmology. So the answer to this question is A. Next question. Which of the following is less likely to differentiate orbital cellulitis from periorbital cellulitis? A. Fever. B. Proptosis. C. Decreased visual acuity. D. Ophthalmoplegia. The orbital septum is a fibrous membrane that extends from the periosteum of the orbit to the inferior and superior tarsi. It lies just deep to the orbicularis oculi muscle. The orbital septum acts as a physical barrier to the spread of infection. Preseptal infections present with eyelid swelling, usually mild, and as you can see in this frame, a port of entry, such as a bug bite, is often seen, as you can see in the upper eyelid of this patient. As we mentioned, preseptal infections can occur due to trauma, such as a few days after a bug bite or during a bacteremia. Usually, it presents in young children. Clinical manifestations are periorbital induration, edema, warmth, and tenderness. The most frequent agents are Staphylococcus aureus, group A Streptococcus, and Streptococcus pneumoniae. Unless the patient looks septic, the patient with periorbital cellulitis can be treated with oral antibiotics. Orbital cellulitis, on the other hand, is a more dramatic condition. Manifestations can be very severe, but at times symptoms can be very mild, as you can see in this frame. Orbital cellulitis or postseptal cellulitis tend to occur in patients with sinusitis. Patients tend to be older, usually more than 10 years of age, but may occur in younger patients after sinus are developed. They present with proptosis, chemosis, decreased visual acuity, and ophthalmoplegia. These findings, especially proptosis, indicate intraorbital pathology. The likely causes are S. pneumoniae, Haemophilus influenza, Moraxella catarrhalis, group A Streptococcus, Staphylococcus aureus, and anaerobes. Patients with orbital cellulitis should be treated with IV antibiotics. So the answer to this question is A. Next question. Enlarged preauricular lymph nodes are more frequent in viral and chlamydial conjunctivitis than in non-chlamydial bacterial or allergic conjunctivitis. A true, B false. Viral conjunctivitis is a benign, self-limiting condition, the famous red or pink eye. The most common agent producing viral conjunctivitis is adenovirus. This condition is not usually associated with pain, photophobia, visual disturbances, or significant amount of mucus discharge. Antibiotics are not helpful. Cold compress may be beneficial. An interesting finding in patients with viral conjunctivitis is enlargement of the preauricular nodes. This new photograph corresponds to bacterial conjunctivitis. Bacterial conjunctivitis is usually a benign condition but requires antibiotic treatment. The eye looks red, as you can see in this picture, but unlike viral conjunctivitis, thick discharge is usually present. This condition is not painful. Photophobia is usually absent, and vision is undisturbed. This is a partial list of agents producing bacterial conjunctivitis. In this frame, I have highlighted 4 agents. Conjunctivitis due to these agents responds well to regular topical ophthalmic antibiotics and are usually not associated with enlarged preauricular nodes. Patients with chlamydial conjunctivitis often do not respond to treatment with regular antibiotics. Hence, suspect chlamydia conjunctivitis when dealing with a patient with bacterial conjunctivitis that do not respond to the usual topical antibiotics, or if some aspect of the history, such as sexual promiscuity, suggests chlamydial as a possibility. Preauricular lymph nodes are often enlarged in patients with chlamydial infection, but not in other bacterial conjunctivitis, as we have just mentioned. The term ophthalmia neonatorum is used to refer to conjunctivitis presenting during the first month of life. Ophthalmia neonatorum is most often acquired during vaginal delivery. Chlamydial, trachomatis, Neisseria, gonorrhea, virus, and bacteria from the maternal gastrointestinal tract and skin are the most common causes. Ophthalmia neonatorum is rare since routine use of an ophthalmic antibiotic was implemented immediately after birth. The image you have been looking at in these prior frames corresponds to ophthalmia neonatorum due to gonorrhea infection. You can see eyelid edema. Patients with ophthalmia neonatorum also show chemosis or swelling of the conjunctiva and purulent discharge. In the case of ophthalmia neonatorum due to gonorrhea, symptoms usually develop 2 to 5 days after delivery. Allergic conjunctivitis is usually bilateral. It is due to irritation of conjunctiva by allergens such as pollen. The eyes are red and itchy. Pain, photophobia, and visual disturbances are not usually present. Treatment consists of eye drops, usually antihistaminic eye drops suffice. Steroids eye drops are seldomly needed. Patients with allergic conjunctivitis should avoid allergens and rubbing their eyes. So the answer to this question is A. Next question. Frequent eye rubbing, especially aggressive knuckling eye rubbing, can produce keratoconus. A. True. B. False. Keratoconus is a vision disorder that occurs when the normally round cornea becomes cone-shaped. Keratoconus causes slight blurry vision, distortion of vision, and increased sensitivity to glare and lights. Keratoconus can be idiopathic, but it is usually a familial condition that can be precipitated by frequent eye rubbing, especially aggressive knuckling eye rubbing. It is found more often in patients with asthma and allergies, in patients with Ehlers-Danlos syndrome, patients with Down syndrome, and retinitis pigmentosa. So the answer to this question is A. Next question. In a patient with corneal abrasion, which of the following findings warrant referral to an ophthalmologist? A. Hypopyon of hyphema. B. Irregular dilated or fixed pupil. C. Extravasation of ocular content. D. All of the above. Corneal abrasion is often seen by plain observation of the cornea. As you can see here, corneal abrasion are painful. The first decision you need to make when managing a patient with corneal abrasion is whether to call an eye consult or not. In order to make such a decision, you need to answer the following questions. Is there visual loss? Is the cornea infiltrated, or is a corneal ulcer present? Is there hypopyon, which is another way of saying is there a pus in the anterior chamber of the eye? Notice the whitish color of the fluid and the presence of a fluid level in this patient with hypopyon. Is there hyphema, which means blood in the anterior chamber? As you can see here, again, notice the fluid level. Is the pupil of the affected eye irregular, dilated, or fixed? Is there extravasation of aqueous humor? If the answer to any of these questions is yes, the patient should be referred to an eye doctor immediately. If the answer is no, you may decide as a general practitioner to treat. The treatment of corneal abrasion consists of no contact lens, the use of antibiotic drops, ointment, or both, the use of long-acting oral non-steroidal anti-inflammatory drugs for pain, and lubricants. Patching of the eye and local analgesic are discouraged. Patients should be referred to an ophthalmologist if no better in 24 hours. The use of fluorescein staining by ophthalmologists or under the supervision of an ophthalmologist may reveal an aberration to be more extensive than initially thought. So the answer to this question is D. Next question. Keratitis means inflammation of the cornea. A true, B false. Keratitis is an inflammation of the cornea. Keratitis can be infectious or traumatic. Traumatic keratitis is often seen with excessive sun exposure, as may occur during skiing with insufficient protected eyewear. The affected eye is red. Pain is practically always present and photophobia is prominent. Vision will be affected, usually in the form of blurriness or inability to see. Eye discharge is often present. Tearing is excessive. Ophthalmology consultation is usually warranted. So the answer to this question is A. Next question. Iritis and anterior segment uveitis are the same condition. A true, B false. The uvea consists of the iris, the ciliary body, and the choroid. The ciliary body and the iris are in the anterior segment of the eye. The choroid is in the posterior segment. The anterior segment is further divided in chambers. The anterior chamber between the iris and the cornea, and the posterior segment between the iris and the ciliary body. Iritis is often used as a synonym for anterior segment uveitis. Choroiditis is often used as a synonym for posterior segment uveitis. The clinical manifestations of iritis are red eye, more prominent around the iris, at the limbus, than in the periphery of the conjunctiva, as you can see in this picture. Pain is frequent. Hypopyon may be present, and hypheema may also be present. Iritis can be acute. Acute iritis is usually idiopathic and it resolves quickly after treatment with a steroid and dilating eye drops. Recurrent, when repeated episodes are separated by gaps of several months. Or chronic. The recurrent and chronic forms of iritis may be associated with systemic inflammatory disorders such as sarcoidosis, rheumatoid arthritis, juvenile idiopathic arthritis, and HLA-B27 associated conditions. Management and treatment of all types of iritis should be done by ophthalmologists. Posterior segment uveitis is usually referred to as choroiditis or chorioretinitis. Posterior segment uveitis present with symptoms such as sudden onset of floaters, blurred vision, loss of vision, distorted vision, and or scotoma. The management of posterior segment uveitis should be done by ophthalmology. An extensive search for cause should be carried out. The eye will not be red unless the anterior segment of the uvea is involved. So the answer to this question is A. Next question. Which of the following conditions is associated with cataract? A. Rubella embryopathy. B. galactosemia. C. Trisomy 21. D. All of the above. Normal lens allows mainstreaming of light. A cataract consists of clouding or opacification of the normally clear lens, leading to failure of the lens to mainstream light. Failure of the lens to mainstream light results in decrease or blurry vision. sensitivity to glare, and color halos around lights. These findings are more prominent at night. The lens has a biconvex shape. The lens consists of a capsule and its interior. The lens interior can further be divided into the cortex and the nucleus. In the anterior pole of the cortex, we find a layer of epithelial cells. These epithelial cells transform into lens fibers by losing all cellular organelles. Lens fibers form the cortex and, to a certain extent, the nucleus of the lens. The nucleus of the lens is created at different stages of prenatal and postnatal development by modified lens fibers. Cataracts can be classified by their anatomical location. We thus can talk about capsular, subcapsular, cortical, nuclear, anterior or posterior cataracts according to their time of appearance. Congenital cataracts are present at birth, although at times not detected immediately after birth. Cataracts can also present during childhood or young adulthood, or at an old age. When cataracts present at an old age, they are referred to as senile. Adult and senile cataracts are more common in patients that smoke, drink excessive amount of alcohol, and are exposed to excessive sunlight. The incidence of cataract increases with age. Cataracts can also be classified according to the etiology or associated accompanying condition. This is a partial list that I hope will help you organize the classification of cataracts based on etiology or associated accompanying conditions. Trisomies associated with cataracts are trisomy 13, also called Patau syndrome, trisomy 18, also known as Edwards syndrome, and trisomy 21, also known as Down syndrome. Congenital infections are also associated with cataracts. Congenital infections associated with cataracts include all torch infection, but especially rubella. Inherited metabolic conditions associated with cataracts are classic galactosemia and galactokinase deficiency. Marfan syndrome. Patients with Marfan syndrome are also prone to lens subluxation and glaucoma. The subluxation is usually superior. Inferior lens subluxation tend to occur with homocystinuria. Marfan syndrome is due to an abnormality in the fibrinogen 1 or FBN1 gene. Alport disease is another condition often associated with cataracts. Traumatic injuries can also produce cataracts. This is a list of traumatic injuries associated to the occurrence of cataracts. As you can see, it includes chemical injuries such as exposure to naphthalene and thallium. Notice the midlines in this photograph. This finding is very characteristic of thallium poisoning. Systemic disorders such as myotonic dystrophy, atopic dermatitis, and neurofibromatosis type 2 can be associated with cataracts. Endocrine disorders such as diabetes mellitus, hypoparathyroidism, and hypothyroidism or cretinism can also be associated with cataracts. And finally, primary ocular diseases such as chronic anterior uveitis, which is the most common cause of secondary cataract, acute angle glaucoma, high myopia, and hereditary fundus dystrophies can be associated with cataracts. So the answer to this question is D. Next question. Acute angioglaucoma is an ophthalmological emergency. A true, B false. In normal circumstances, aqueous humor is produced by non-pigmented epithelium of the ciliary body. Then the aqueous humor flows anteriorly through the pupil. About 90% of it drains through the trabecular meshwork in the iridocorneal angle, reaching Schmel canal, thus exiting the eyeball, and about 10% drains into the iris and ciliary body, exiting the eyeball through the choroid and sclera. This is called the uveoscleral pathway. A malfunction of these draining systems produces glaucoma. Medieval Arabic authors translated glaucoma as tharka. Glaucoma can be divided into open angle and close angle glaucoma, based on the degree of angle formed by the cornea and the iris. The term wide angle glaucoma is often used for open angle glaucoma and narrow angle glaucoma for closed angle glaucoma. We will address open angle glaucoma first. In open angle glaucoma, the angle between the cornea and the iris is wide. The drainage system is clogged. The intracanalicular block can be due to white blood cells, red blood cells, or retinal debris. Sometimes they are blocked, but we don't know why they are blocked. Risk factors for open angle glaucoma are old age, family history, and being African American. Clinical course is characterized by no pain and a slowly progressive blindness. Close angle glaucoma is produced by forward displacement of the iris closing the entrance of the major draining system. It starts by obstruction of normal flow through the pupil, followed by fluid buildup behind the iris, pushing the iris towards the cornea, thus closing the angle between the iris and the cornea. It is this displacement of the iris that produces glaucoma. The lens follows the iris and become displaced forward as the pressure inside the eye increases. Close angle glaucoma is an emergency. Mediatics are contraindicated. Close angle glaucoma present with extreme frontal headaches, distorted vision, red eyes, severe eye pain, vomiting, and halos around light. Chronically or acutely in open or closed glaucoma, the pressure inside the eye increases, and then optic nerve fibers are damaged. Fundoscopy is the key to detect early cases. Normally, the cup to this ratio is about 0.2. Here I have indicated the normal cup. A ratio of 0.5, that is a cup that occupies 50% of the disc, is probably abnormal. A cup that occupies 70% of the disc is certainly abnormal, and so is a cup that occupies 90% of the disc, as you see here. At times, you see, in addition to the big cup, bleeding, as shown in this frame. So the answer to this question is true. Next question. The medical treatment of acute angle closure glaucoma aims to decrease the intraocular pressure by blocking the production of aqueous humor, increasing the outflow of aqueous humor, and reducing the volume of the aqueous humor. A true, B false. Acute angle closure glaucoma treatment requires a combination of medical and surgical approaches. Definite treatment is surgical. It consists of peripheral iridectomy after the acute episode subsides, Peripheral iridectomy can be done using laser or surgical treatments. Laser iridectomy is the treatment of choice. Surgical iridectomy is indicated when laser iridectomy cannot be accomplished or is unsuccessful. Medical treatment is just as important and is always the initial step in the treatment of acute angle closure glaucoma. Medical treatment of acute angle glaucoma consists of decreasing the intraocular pressure by acting upon three aqueous humor factors: blocking production of aqueous humor, increasing outflow of aqueous humor, and reducing aqueous humor pressure. It is important to remember that mediatric agents, that is alpha-1 adrenergic agonist, should not be used in patients with close angle glaucoma. So the answer to this question is A. Next question. Prostaglandin is used in the treatment of glaucoma because it dash of aqueous humor. A. Blocks production. B. Increases outflow via trabecular meshwork. C. Increases outflow via uveoscleral pathway. D. Reduces volume. I hope you recall this diagram. We use it to answer the last question. Blocking production of aqueous humors is achieved by the use of intravenous acetazolamide. Acetazolamide inhibits carbonic anhydrase. Acetazolamide produces no pupillary or vision adverse effects. And by the use of topical alpha-2 adrenergic agonists such as brimonidine or beta adrenergic blockers such as timodol. Topical adrenergic beta blockers have no pupillary or visual adverse effects, hence it is the preferred medication by many ophthalmologists. Drugs that increase aqueous humor outflow are of two types: cholinomimetics. Cholinomimetics increase outflow via contraction of the ciliary muscle and opening of the trabecular meshwork. The adverse effect of cholinomimetics are miosis due to pupillary sphincter contraction and cyclospasm due to ciliary muscle contraction. The second type of drugs that operates by increasing outflow are prostaglandins. Prostaglandin, such as pimatosprost, increases flow via the uveoscleral pathway. The adverse effect of these drugs are darkening the color of the iris and promoting eyelash growth. The third type of drugs used in the treatment of acute angle closure glaucoma aims at reducing the volume of the vitreous humor, thus allowing for the expansion of the anterior segment of the eye, leading to decreasing the pressure of the aqueous humor within the anterior segment of the eye. The drug used for this purpose is mannitol. This drug is used by ER physicians and ophthalmologists to treat acute angle glaucoma in the emergency room. This drug is not mentioned in the USMLE First Aid 2020. So the answer to this question is C. Next question. Eye drops generally are the initial treatment of choice of open angle glaucoma. They reduce intraocular pressure by decreasing aqueous production or increasing aqueous outflow. A true, B false. Treatment of open angle glaucoma is mostly medical. It is aimed at decreasing the intraocular pressure, either by blocking production of aqueous humor, by the use of topical adrenergic beta blockers, or increasing outflow. Outflow can be increased by the use of cholinomimetics, as previously mentioned. Cholinomimetic drugs open trabecular meshwork by producing ciliary contraction, or by the use of prostaglandin In addition to medical treatment, surgical treatment is an option. Laser trabeculoplasty or surgical trabeculectomy is indicated when the intraocular pressure cannot be reduced medically. Laser trabeculoplasty consists of focusing light rays being directed to the trabecular meshwork. This procedure produces a reaction in the pigmented epithelium and often leads to increased aqueous humor flow via the trabecular meshwork. So the answer to this question is true. Next question. Which of the following drugs decreases aqueous humor production without producing mydriasis? A. Alpha-1 agonist, B. Alpha-2 agonist, C. B2 agonist, D. B1 agonist. This is a histological representation of the human ciliary body. The ciliary body contains muscles and epithelium. The epithelium is of two types, pigmented and non-pigmented epithelium. The non-pigmented epithelium is in charge of aqueous humor production. Drugs that stimulate alpha-1 and alpha-2 receptors, referred to as alpha agonists, decrease the production of aqueous humors. Drugs that stimulate beta-1 and beta-2 receptors, referred to as beta agonists, increase the production of aqueous humor. The iris has a circular muscle which, upon contraction due to activation of muscarinic 3 receptors, produces miosis. The iris also has a radial muscle which, upon contraction due to stimulation of alpha-1 receptor, produces mydriasis. So the answer to this question is B. Next question. Beta-2 agonist eye drop increases aqueous humor production and produces closure of the meshwork and Schlemm canal. A true, B false. This question has two parts. The first part deals with production. As I hope you recall by looking at this figure, beta-2 adrenergic agonists increase aqueous humor production. The second part of this question deals with outflow. The aqueous humor is produced by non-pigmented epithelial cells of the ciliary body, as we have previously mentioned. The aqueous humor flows from the posterior chamber to the anterior chamber of the anterior ocular segment between the lens and the iris. Most of it flows out of the anterior chamber via the trabecular meshwork and the Schlemm canal pathway. This flow is governed by activation of muscarine 3 and beta-2 adrenergic receptors. Activation of M3 receptors open the pathway. Activation of beta-2 adrenergic receptor closes the pathway. In addition to the via trabecular meshwork Schlemm canal pathway, there is a second smaller pathway, as we have previously mentioned, called the uveoscleral pathway, depicted in this frame. This pathway is influenced by prostaglandin. Prostaglandin increases the volume of humor going through it. So the answer to this question is true. Next question. Which of the following eye drops decreases aqueous humor production by decreasing ciliary body blood supply? A. Alpha-1 agonist, B. Alpha-2 agonist, C. Beta-2 antagonist, D. Beta-1 antagonist. I will be using this representation of the anterior aspect of the eye to explain the mechanisms of some of the drugs used in the treatment of glaucoma. On the left side, I will represent the receptors involved in the innervation of the ciliary body epithelium that are involved in the production of aqueous humor. Alpha-1 receptors are present in the vessels irrigating the ciliary body epithelium. Alpha-2 receptors, beta-1 and beta-2 receptors are present in the ciliary body epithelium. On the right side of this frame, I will represent the receptors involved in muscle innervation. Muscarinic 3 receptors are present in the circular iris muscle and in the ciliary muscle. Beta-2 receptors, in addition to being present in the ciliary epithelium, are also present in the ciliary muscle. Alpha-1 receptors, in addition to being present in the vessel irrigating the epithelium, are also present in the radial iris muscle. We are going to mention 6 mechanisms of actions of drugs used to treat glaucoma. The reason I am dwelling on the mechanism of action of glaucoma drugs is that questions regarding this topic are often asked in the USMLE Step 1. The first of the mechanism I will mention is decreasing aqueous humor synthesis by direct autonomic system-mediated action on the aqueous humor production by the ciliary body. This mechanism is employed by alpha-2 agonist. Notice that alpha-2 adrenergic receptors are only present in the ciliary body epithelium. The same mechanism of action is used by beta blockers. Notice that unlike alpha-2 adrenergic receptors that are only present in the epithelium of the ciliary body, beta-2 adrenergic receptors are also present in the ciliary muscle. We will go back to this point in a few seconds when we talked about the 5th mechanism of action of glaucoma drugs. The second mechanism is decreasing aqueous humor synthesis by decreasing arterial flow to the ciliary body. This is the case of alpha-1 agonist. It is important to remember that since the radial muscle of the iris has alpha-1 receptors, alpha-1 agonists also produce mydriasis. Hence, alpha-1 agonists are contraindicated in the treatment of close-angle glaucoma. The third mechanism is decreasing aqueous humor synthesis via inhibition of carbonic anhydrase. This is accomplished with the use of oral use of acetozolamide. The fourth mechanism is decreasing aqueous humor pressure by drawing water out of the vitreous humor of the eye. This is the mechanism of action of mannitol. The fifth mechanism is increasing outflow via trabecular meshwork Schlemm canal pathway. This is the mechanism of action of cholinomimetic drugs, which also produce meiosis by stimulating the circular iris muscle. Increased outflow through the trabecular meshwork Schlemm canal pathway is also achieved by the use of beta-2 blockers. The sixth mechanism consists of increasing outflow via the uvoscleral pathway. This is achieved with the use of prostaglandins. So the answer to this question is A. Thank you very much for your attention.